Mahdi for her kind invitation. Now it's a pleasure to present Professor Cecily Quinn, consultant histopathologist at St. Vincent University Hospital, Dublin, Ireland. She is chair of European Working Group for Breast Screening Pathology, clinical vice chair of the European Cancer Initiative for Breast Cancer Guideline Development. Her research interests include the pathology of early neoplastic lesion of the breast and prognostic predictive markers in invasive breast cancer. She has over 130 publications in peer-reviewed journals. She is going to talk about spindle cell lesions of the breast.
Thank you. So, wonderful. Good morning or good afternoon, I think almost at this stage, everybody. It's a very great pleasure to be back in Cairo. I was here 10 years ago, and like Abir, I participated in the virtual meeting last year. I would like to thank especially Dr. and Professor Manal for the invitation and to the organisers for a superbly organised meeting. It is, as I said, a great pleasure to be here. So my talk today is, I'm going to speak about spindle cell lesions of the breast. And is there an echo? Or you can hear me okay? Yeah, okay, good. So spindle cell lesions of the breast are very challenging lesions for the pathologist. All soft tissue spindle cell lesions that we see in various parts of the body may occur in the breast, but they are less common than epithelial lesions. Thank you, yeah, better with the lights down, yeah. The problem with spindle cell lesions is that the morphology overlaps. Benign lesions may look malignant, and malignant lesions may look benign. So in the course of this talk, I would like first of all to outline a general approach to the evaluation of a breast spindle cell lesion, and secondly, for this latter half of the talk, to have a brief discussion of the specific entities that enter into the differential diagnosis based on a few case presentations. So I'd like to start first of all by showing you these two slides, and I'm going to ask you to decide which is benign and which is malignant. And at the end of the talk, I'll tell you which is which. I think you'll agree that based on the available evidence, it's very difficult to distinguish between them. And this reminds me of an analogy that used to be used by Professor Ashley Price. When I was training in London, I worked for some time at Northwick Park Hospital. And when he was giving a talk on the evaluation of various pathological findings, when you were trying to differentiate between ulcerative colitis and Crohn's disease, he frequently showed these two identical bricks, and then went on to tell us that one was from this pretty garden cottage, and the second is from Buckingham Palace. So I think this illustrates very well how it's very difficult to make a diagnosis based on one single finding. So when we're looking at spindle cell lesions of the breast, like indeed any pathological condition, if we want to reach the correct diagnosis, we need to stand back and take a global view of all the information at our disposal. First of all, look at the clinical history. There may be some very useful information there. The radiological findings may be informative with the gross findings. Clearly, our H&E findings. We need to maintain a broad differential diagnosis, judiciously use immunohistochemistry, and molecular tests if they're available to us. So when we've done all of that and taken account of all of the other information, we should have a look at the slide. So you'll all know Professor Emad Raka, who with his colleagues from Nottingham published this paper in Histopathology in 2016. And this was his approach to the diagnosis of spindle cell lesions. I had the pleasure of updating this approach with him in this publication, which appeared in the breast issue of Virchow's Archives last year. So the approach that we have taken, and that was really pioneered by Professor Raka in his earlier paper, was to divide spindle cell lesions into those that look bland or look benign, and those that look malignant. And that may sound a little bit simplistic, but the advantage of that approach is that it encourages us to consider a malignant diagnosis when we're looking at something that looks bland, And similarly, to bear in mind that some benign conditions may in fact look very alarming on H&E. Clearly, of course, we also divide these lesions into pure or mixed. Diagnostically, the main difficulty is with the pure lesions. If we have a mixed lesion, often the diagnosis is more clear at the outset. So when we look at our H&E slide, first of all, we should look at the cells. Are we looking at a pure spindle cell population or a mixed population? Clearly, if we have a high-grade spindle cell lesion with carcinomatous areas, we know that we're probably dealing with a metaplastic carcinoma. We should look at the degree of atypia. That can be very helpful. We look for mitotic figures, and if we see them, are they normal or are they abnormal? Very important in spindle cell lesions. Look at the growth pattern. Is it storiform, fascicular, or whorled? Look at the outline of the lesion. If we have a very well circumscribed spindle cell lesion, it's unlikely to be malignant. Look for obvious features like necrosis. Again, generally speaking, but not always, necrosis will be an indicator of malignancy. And then look for clues, other clues that may help us. So it is important to try and do as much as we can with the H&E before we order immunohistochemistry. So some clues to a diagnosis might be this top left picture here. We see calcification in a spindle cell lesion. And there's a little bit of adjacent fat necrosis. So the appearances there suggest organizing scar with calcification. The middle picture, we can see spindle cells with some red blood cells, and that might make us think of nodular fasciitis. On the extreme right here, we have a spindle cell lesion in which there is some mitotic activity. So less likely to be fibromatosis, going towards spindle cell, low-grade fibromatosis like carcinoma. Clearly then, if we find DCIS beside a spindle cell lesion, we're probably dealing with metaplastic carcinoma. If we see epithelial line clefts, that we think of Phyllodes tumor. And finally, these are just examples, but if we see pigment in a spindle cell lesion, bear in mind the possibility of metastatic malignant melanoma. And I've seen a few of these present as screen-detected lesions in recent times. So clearly, when we're evaluating spindle cell lesions, immunohistochemistry is hugely helpful. And for many laboratories, it is still the mainstay. Most working laboratories at this stage do not have full access to molecular studies. I'm not going to clearly go through all the immunohistochemistry stains that we use, but just to mention a few. Cytokeratin is clearly our first-line stain if we're considering a diagnosis of metaplastic carcinoma. And that's really our top differential in both bland-appearing and malignant-appearing spindle cell lesions. With cytokeratin, it's very important to use a panel of antibodies. Broad spectrum, high molecular weight, low molecular weight, luminal and basal. And to bear in mind that staining may be focal or absent in metaplastic carcinoma. And that's particularly important on needle core biopsy. And we should repeat on excision if cytokeratin negative on core. Now, it is important to remember that metaplastic carcinoma may co-express mesenchymal markers, and that, on the other hand, you may see focal cytokeratin positivity in the stroma of Phyllodes tumor and in leiomyosarcoma. So nothing is absolute. P63 can be very helpful, and it's positive in about 90% of cases of metaplastic carcinoma. It's very useful in cytokeratin negative cases. It should be negative in the stromal, non-malignant spindle cells, and it is usually negative in Phyllodes tumor. However, again, caution, we may see focal P63 positivity in some high-grade Phyllodes tumors, and that may lead to confusion with metaplastic carcinoma on a core biopsy, particularly if the spindle cell lesion is CD34 negative. CD34 is a very helpful antibody. It's positive in many benign spindle cell lesions such as myofibroblastoma, spindle cell lipoma and PASH. It is also positive in the majority of phalloides tumours, but it is well described that the staining tends to be less intense in high-grade phalloides tumour. Also, it's clearly positive in vascular lesions. Important negatives are spindle cell carcinoma, fibromatosis, and nodular fasciitis. Beta-catenin is clearly helpful in the diagnosis of fibromatosis. We see nuclear staining in most fibromatoses. However, we can see focal weak nuclear staining in spindle cell carcinoma, phalloides tumour, and scar. So clearly, we should never rely just on a beta-catenin to make a diagnosis of fibromatosis, and increasingly these lesions are not now excised from the breast. So it's very important to ensure that we use cytokeratins and that we don't miss a diagnosis of fibromatosis like metaplastic carcinoma. These are just some tables I've included for completion, and they will be in the PDF, just antibodies that are helpful in the diagnosis. Molecular studies are clearly emerging really to the forefront of diagnostic pathology, and I guess in a few years they will be like immunohistochemistry was back in the 90s, coming in. We're like the 90s now, but it will be part and parcel of our daily armamentarium. And clearly there are specific genetic alterations described in fibromatosis, nodular fasciitis, myofibroblastoma, metaplastic carcinoma, and individual sarcomas. So clearly, if we are suspecting a particular diagnosis and having difficulty with it on immunohistochemistry, molecular studies may help to clinch the diagnosis. So if the diagnosis is not clear, having adopted that approach, it's always good to stay friends with your soft tissue colleague who can help you a lot with these kind of cases. So you know what they say. They used to say a picture is worth 1,000 words. Now they say a JPEG is worth 1,024 words. So I was going to show you a few cases and to talk about the differential diagnosis of the various lesions. So just remembering the approach, the bland looking and the malignant looking lesions with emphasis on the pure. I like to think of these in 3 lots of 6. So first of all, we have the bland looking pure spindle cell lesions with an irregular contour. These tend to be more difficult. Top differential is fibromatosis like metaplastic carcinoma. And I've included the other irregular lesions there, such as fibromatosis, etc., bearing in mind, of course, that some low-grade sarcomas, like angiosarcoma, can mimic a benign spindle cell lesion. So first of all, the first case history, female of 45 who presented in August of 2014 with a small lump in her right breast. And this was sent to us by the radiologist as R4. I'm sure as pathologists you would agree with me that sometimes you wish you were a radiologist, that you could say everything is B4, maybe benign, maybe not, but we have to make the final diagnosis. So I think sometimes they have a hard job, but when it comes to actually nailing it down, I'm afraid it's down to us. So on core biopsy, we have a bland appearing spindle cell lesion here with an irregular contour. When we look at higher power, we see plump cells. We don't see really any atypia, and there are no mitotic figures. Beta-catenin was positive in this case. Everything else was negative. We call this fibromatosis, and it was a B3 lesion. So in fact, this case was excised, but obviously there is a move towards not excising these. So just in terms of differential, if you want to have a go at these, this is another irregular lesion. This one, the cells are more plump, there is mitotic activity, so this is really what we don't want to miss. This was strongly AE13 positive, and also it can obviously show P63 positivity, CD34 negative, triple negative, so this is fibromatosis like metaplastic carcinoma. Next one, again, we have a spindle cell lesion here. The cells are quite plump. I think it might be difficult to see with the light, but we do have fat necrosis here. This one is smooth muscle actin positive, and this is a scar. And very often these turn up, particularly in patients who've had a surgical excision many years ago, and they come back often as calcification in their follow-up mammograms. This is a nice case, and I'm sure you'll recognize this instantly from the H&E, and you can see the very characteristic slit-like spaces here. This is CD34 positive, hormone receptor positive. This can occur as an isolated finding, occur in a hamartoma, or in gynecomastia. So this is PASH, exactly. So they're just some examples of irregular, bland-looking lesions. Moving on those to the ones that have a round contour. Top of the list here is usually myofibroblastoma. Phyllodes tumor, yes, but usually they don't present just as stroma if they're benign, and if they're malignant, there's usually much more atypia. And there I've listed the other lesions there. So just looking quickly then at case history 2, this is a male of 75 who came with a palpable nodule in his left breast. He had a past history of prostatic adenocarcinoma. Usually I find, and not being cynical about this, but if the clinicians give us information, usually it turns out not to be helpful, but when there is some key information, they sometimes forget to tell us. But here we have the excision specimen, and you can see again the spindle cell lesions, interspersed collagen bundles and fat spaces. This lesion has a very nice rounded contour. Here's the immunohistochemistry, CD34, desmin, and some hormone receptor positivity. And this is, of course, a myofibroblastoma. This is an example here of a fibroepithelial lesion in which we see just stroma on that first shot. But as I said, usually these do not present as bland spindle cell lesions, but do keep them in mind. And if you only see a spindle cell component on the core biopsy, the radiology may help you to suspect phyllodes, and usually, as I said, you will get CD34 positivity, but it tends to be less intense on high-grade lesions. This is an example of a leiomyoma, another consideration in the differential of a round spindle cell lesion. And here we have nerve sheath tumors, schwannoma, and neurofibroma. So moving on then for the last few minutes to the malignant-looking pure spindle cell lesions. Again, top of the pile, top of the list is always metaplastic spindle cell carcinoma, followed really by malignant phyllodes tumor, and then the various other considerations. So this is a female of 57 with a screen-detected lesion in her right breast. She had a 15 millimeter or 5 mass in this case, and an abnormal node in her right axilla. And that's her ultrasound image. And here's the core biopsy, and you can see immediately this very cartilaginous appearance with these very atypical spindle cells that were strongly A13 positive. So this was an easy, straightforward diagnosis of a metaplastic carcinoma. Interestingly, this lady also had a positive lymph node, which we don't often see in metaplastic carcinomas. They tend to spread more via the hematogenous route. Here is an example of a malignant phyllodes tumor, and again, this is, of course, if we have a malignant appearing spindle cell lesion and nothing else, that's a big consideration. And here we do have some CD34 positive, but clearly you need to ensure that it's cytokeratin negative, and thorough sampling is advised on an excision specimen because you may find an epithelial component that helps with the diagnosis. Excuse me. This here is another example of a malignant appearing spindle cell lesion with an irregular border, mitotically active, and a history of rapid growth. And these can be quite confusing if you don't take everything into consideration. SMA positive, everything else negative. So what is it? Nodular fasciitis, exactly. Now my final case history then is a female of 69. And she presented in 2011 with bilateral breast lesions. Now, this came from core biopsy from the radiologists, who are very good at giving us information. And they told us at the time of biopsy that this lady had a past medical history of a leiomyosarcoma. And this was our core biopsy, a malignant appearing spindle cell lesion, mitotically active, no real clues as to exactly what it might be. SMA positive, desmin positive, cytokeratin can be positive. In our case, we didn't have positivity. So putting everything together, this was in keeping with the diagnosis of metastatic leiomyosarcoma. This was removed, and the patient later went on to have metastatic deposits removed from her lungs and did quite well following surgery. So interpretation of that case reminds me of another GI pathologist. I don't know, I'm sure Abir knows, but I don't know if you all know Neil Shepherd. He's a GI pathologist in the UK. And I heard him give a lecture once on interpreting granulomas in the GIT. So he said, what are the 3 most important things you consider when you're looking at a granuloma in a biopsy from the GIT? And everybody wondered, and of course the 3 considerations were context, context, and more context. And I think this is very true of evaluating spindle cell lesions. So clues to metastatic disease are multiple lesions, bilateral lesions, odd morphology, no DCIS, triple negative, a history of malignancy, and it's always good to compare with the previous. And these are the lesions that most commonly metastasize to the breast. So to conclude, spindle cell lesions of the breast are very challenging. The morphology overlaps. Benign may look malignant, and malignant may look benign. It's very important to keep an open mind and maintain a broad differential, use immunohistochemistry and molecular tests as guided by the morphology, and always remember context. So, benign or malignant? Well, the one on the left is granulation tissue, the one on the right is metaplastic carcinoma, but clearly pretty indistinguishable with those snapshots. So I would like to say thank you again and to say what a pleasure it is to be here. My husband and I spent a few days visiting the wonderful sites of Egypt, and I have to say you have a beautiful country. It's -2 in Dublin at the moment, so it's a very great pleasure to be here in this lovely sunny climate with you. Thank you.
Thank you very much, Professor Cecily, for your informative, practical lecture presentation. Now